me or things that you're interested in making sure I pay particular attention to. If you don't feel like speaking up, that's okay too. You can stop me as we go through the questions. Do you want to volunteer anything right off the bat, or we'll just kind of
Well, I'll say that I'm not currently in treatment, so I would obviously defer to anyone who is, but one of the things that I've been curious about through our support group meetings is the changes that have come about in how you diagnose the specific the cancer of the specific patient through genetic testing and all these different things. There's just so much. Newer patients would come into our group and talk about things that I never heard of when I was in treatment. And it seemed to be much more targeted. So that's something that interests me, but again.
Sure. I think we may get to some of that, or we may need to go into a little bit more detail when we get
Totally fine.
Come around the treatment area, but that's great. Anybody else want to volunteer anything, or we'll just kind of get going? Okay. Stop me anytime. Oh, keep going. Okay, so you may know colorectal cancer starts in the colon or rectum, and under the microscope can look really similar. This is oftentimes just a mechanical or a location-based assessment up front, but the treatments can be slightly different. Third most common form of cancer diagnosed in men and women in the United States. The number of people dying from colorectal cancer thankfully has declined over the past 20 years with advances in treatment, as well as early detection. Screening for and removing of polyps is the best way to prevent colorectal cancer before it even starts. It is an effective screening tool. We have a way to look for this. It's common enough disease that it makes sense to recommend for everyone. And as you may have heard, just in the past year and a half, 2 years, the recommended screening age has gone from age 50 down to 45 for everyone. Signs and symptoms, most commonly are changes in bowel movements, blood in the stool, sometimes abdominal discomfort, maybe weight loss for no known reason, although it's pretty unusual that that's a presenting symptom. Constant fatigue, most likely from anemia, and vomiting. So commonly, all patients will get all or most of these tests with physical exam, colonoscopy, blood tests, and we can talk a little bit more about that with the point in the direction of diagnosis of colon cancer. Scans, most commonly CT scans, although MRIs are often used in the workup of patients with rectal cancer. And then sometimes patients are not diagnosed until they go for an operation, especially if they present with pretty significant symptoms and have to go to the operating room emergent. So this gets a little bit at your question, John, about biomarker testing. So biomarker testing can help us understand a little bit more about the diagnosis and which treatments are right for patients. Some of the more common biomarkers that are looked at are, first of all, the question of whether or not a cancer is what we call microsatellite instability high, or MSI high, or has deficient DNA mismatch repair. So this is a concept that's hard, I think, a little bit to understand or even explain, but that some patients and some cancers have a lot of DNA instability, so that they don't repair the DNA errors very effectively. Well, if a patient has a genetic risk for this happening, an inherited risk, they may be more likely to develop a cancer. Cancers that are MSI high or deficient DNA mismatch repair, because they're so unstable, can be more susceptible to chemotherapy, and specific also immunotherapy. So we've known for a long time that, again, there are patient families who will be at high risk for developing cancers in a familial syndrome called Lynch syndrome, and those cancers often are MSI high. So more likely to get the cancer, but if they get the cancer, it actually is less likely to come back and less likely to spread. So really kind of an unusual conglomeration of things happening. But then in the advanced setting, we use that MSI high information as a marker for susceptibility to immune therapy. So that's one kind of bucket of molecular testing, and we more and more now use that information even in the localized setting, although it's a rare finding in colorectal cancer. Still probably 6% or fewer of patients with colorectal cancer. In the advanced setting, there are other targets that we may look for, which could impact the treatment. And the most common ones are listed here: BRAF, HER2, which is more commonly abnormal in breast cancer, but in a subset of patients with colorectal cancer, their cancers will also have HER2. That protein will be one of the drivers for their cancer, and then consequently we can target it. KRAS or NRAS, which affect our treatment choices. We're not great yet at targeting those in colorectal cancer, but we're working on it. And then NTRK, which is a rare finding, but we're interested in finding it because we have a drug that can work on that, and sometimes work fairly effectively. So those are all just examples, and those aren't the only things they look at. Every time they do a new testing, sometimes they'll expand the panel of genes, or we used to say mutations, but not everything is a mutation. I don't want to get too much into that. There might be what we call fusions, or there might be overexpression of things. So there could be a lot of different ways where we have alterations in genes that then we can connect with drugs. And I can stop here and talk if there's more people have questions, or yeah, fire away.
So just could you tell us, is the biomarker testing based on blood tests or testing tumor tissue?
Great question. So there are a lot of different ways you can test. Sometimes we want to know about what's in the cancer because we want to treat the cancer, and so that is kind of what we call somatic testing. You look at what's in the cancer, and it affects your treatment for the cancer. Sometimes when we talk about genetic testing, people are worried about their gene risk, their family gene risk, is this inherited? And those you can test in even just a cheek swab, saliva, or a blood test. Now, for the tumor, you can also test for evidence of tumor DNA shed in the bloodstream. And that, as you can imagine, can be sometimes hit or miss, but the testing is getting so much better that a lot of times you can identify tumor DNA in the bloodstream that can give you information about what's going on in the tumor. And then even kind of cooler beyond that is that you can see that change over time. So that you can see that the mutations or the alterations may change over time, and the levels of those may change over time. We're still in the figuring out how to use all that information. What does it mean? What can we identify? But to your question, many times now we can find it both in the tumor and in the blood test. And sometimes if there's not enough tumor left after a biopsy, for example, we might do a blood test. We also might just do a blood test to see. We're not quite there yet in routine care, but we might do that as a response to therapy. I would expect in the next 2 to 3 years that'll be more and more common that people will be doing that.
Did someone see Sarah's question up there? Something
I
Let's see,
saw it.
look there. Why is biomarker testing involved in advanced or metastatic if it's local? Would this testing help predict likelihood of recurrence or otherwise help? Very good question that we, in some cases we know the answer to, in some cases we don't. So we've now moved the microsatellite instability because it does affect the risk of recurrence and potentially it affects our risk of our choice of treatment from our standard chemo versus otherwise, or sometimes even avoiding standard chemotherapy altogether, because patients with really localized disease who have whose cancer is MSI high have such a lower risk, then that they may not even need chemotherapy. We may be able to afford chemotherapy. So obviously that's a really valuable thing to find. The reason that the other alterations are now not routinely done in the localized setting is because those drugs we don't use in that localized setting. So none of the targets are we using in the localized setting, and we really don't know if those alterations really predict a worse recurrence. So one of the examples is BRAF. BRAF is thought to be in general. BRAF in general is thought to be associated with a worse overall outcome. However, we all have patients. I have one patient who was a Gilda's patient for over 10 years who's had a BRAF mutation. But we don't know if that translates into the localized setting. And those kinds of really specific, what does the biomarker mean in the localized setting, especially because in general, most patients with colorectal cancer that is localized will do well. It's hard to get all that data quickly, and we've only really been sequencing in this space for a few years. So I don't know if that answered the question, Sarah, but we use the ones that really affect that we know affect the prognosis and or the treatment. We use those in the localized setting. Again, because most patients in the localized setting will do well, and the testing is not cheap. It's not out of reach, but it's between $3,000 and $5,000 for every patient. So the cost of healthcare, if we were testing a lot of patients who never were going to have their cancer come back, it's another, is that how we should spend our healthcare dollars if the patients are going to be fine? Anyways, all those extenuating circumstances, but we use the MSI high in the localized setting. Okay.
Can I ask one
Of course.
follow-up question? Is the DMMR the one that this has been maybe 6-8 months ago, there was a study where they treated 14 patients and they all were cured 100%?
Yes, exactly. So that was so there was, so MSI high and DMMR are basically two ways to do the testing to get at the same cancer. DMMR is you take a cell and you kind of stain for the protein, and if the protein's not there, you say it has deficient mismatch repair proteins. And then MSI high, I gotta be telling you, I've read a whole bunch of times. I don't do the testing, but it's this complicated way where you do match the microsatellites and the normal and the other. But basically, they're two sides of the same coin. So the question that you're asking is about a very particular study, which was done in early stage rectal cancer. And rectal cancer is, it's another piece that's important, is that the colon, as you go up and across and down and into the rectum, the prevalence of these alterations changes depending on where in the colon they are. So rectal cancer is more likely to have to not have any of these other alterations that take out their sensitivity to immune therapy. They specifically looked for MSI high patients with rectal cancer in early stage and treated them all with a drug that is, I don't think is still yet on the market, a drug called Starlab, but it's a drug essentially very similar to drugs that many people have heard of because they have a lot of commercials, like Keytruda or Opdivo or some of those other immune therapy medications. And they, although it was still early, and they had 100% response rate. So they had all of those cancers shrink. So it was again, really small study, very specific patient population, a very early stage, but very exciting. Very much a proof of principle, especially with lower rectal tumors, especially one, if you could avoid surgery, everybody wants to avoid surgery if they can, and if they don't need a colostomy, that's obviously a tremendously important outcome, and minimizing having to go through any of the other things. So it's not yet quite a standard of care to get just immune therapy and then follow, although there are a lot of folks moving into what we call a watch and wait approach for rectal cancer just in general, because again, a lot of patients will respond to, so you have the MSI high patients who will respond really well to immune therapy, and that was that particular group. You also have a lot of patients who will respond really well to chemo and radiation and avoid surgery. And so we are looking more and more at how we can safely do that, not have, years down the road, the cancer come back. Are these patients really cured and for real, or are we just seeing a kind of a short-term response? So we're definitely not figuring that out. Phase of that too. Super complicated concepts, and I'm still figuring out how I best explain them. So if it's not clear, please stop and ask clarifying questions. So we'll see where we go to on the next slide. So this gets back at the staging, and I was telling fellows who are our students who had a lot of training that they, staging for colorectal cancer is fairly straightforward. That 0 and 1 are pretty superficial, and then in stage 3 is usually involving lymph nodes. Stage 4 has spread from wherever it started to another organ. So we use these, and then stage 2 is deep in the walls. So that kind of so I always easier to work with the outside in to understand a little bit of staging. And we use things, they talk about this with TNM, tumor node, and metastases as it's spread to other organs. And really, this is how we end up giving cancer to a stage, and we use the staging to give us some sense of stratification on where patients will benefit from different treatments, and to some degree, overall prognosis. This shows that a little bit. See, most of these cancers will start as a polyp, and then they work their way. You can see. Oh, you can see my mouse. They work their way into the wall. So you see, stage 2 is deep within the wall, but does not have the cancer in the lymph node. Stage 3 has cancer in the lymph nodes, and most often is deep in the wall, but not always. And then stage 4, the cancer has spread to another organ. For colorectal cancer, most common places it goes, for colon specifically, to the liver, sometimes to the wall of the belly cavity, so kind of just free floating in the belly. And then sometimes, especially for lung, may skip the liver and go to the, for rectum, may skip the liver and go to the liver. So could go, cancer unfortunately can do anything that it wants to, but those are the most common patterns that we see.
Excuse me, wall of the belly cavity, do you mean like the omentum? Or what is the wall of the?
Yeah, so the omentum or the peritoneum. So it's, the omentum is really that kind of, someone described it as sort of like a layer of saran wrap that holds the colon in place, but it can be on sort of the outside. So if you think of, and I think it's a concept I tried to refine how I explain, but still hard. If you think of like your belly wall, like a skin wall, there's a lining on the backside or the inside of that, and cancer can just take up residence there. So it's not exclusive to the omentum, but the omentum or the peritoneum. So this gets into all the different folks involved in the healthcare team, and this isn't even all folks, right? There's lots of different types of cancer doctors, and then we work often with oncology nurse practitioners or physician assistants. So, you know, I always work with a cancer surgeon, and actually cancer surgeons can take it for different flavors. They can be surgical oncologists, they can be colorectal surgeons. Sometimes our hepatobiliary surgeons are involved with those with the liver and bile duct, and if cancer is spread to the liver, those folks may be involved. And then the radiation is done by a completely different doctor. For me, I do chemotherapy as the kind of treatment that I give, and then oftentimes serve as, to some degree, the quarterback of the team. But we work with I work with nurse practitioners and PAs. We have a team of social workers who are tiny but mighty and who wish we had more. We work with nutritionists, patient navigators. We have embedded clinical pharmacists who help us with the not only just the chemotherapy dosing, but as well as the interactions. We partner with primary care physicians when we can. I know the ones who are great, and then there's lots of folks who won't have one. We have financial counselors on staff, and then you know, we work with cancer rehab physicians and palliative care physicians and all sorts of other folks that we work with, pain specialists, all kinds of. The radiologists are very involved in the care. They don't directly interact, but now that patients have open release of results, they sometimes feel like they interact with the radiologist and have certain thoughts about who they like and don't like or understand. So, so if you know, I don't know, this group seems like a pretty sophisticated group or maybe an experienced group, and so these are some things, but obviously I do think it always helps to make a list of questions. My brain freezes all the time, so having a list is very helpful, letting us know what's happening with side effects and symptoms, making sure we know about other medications, and particularly supplements. I have had that experience where folks had a lot of side effects from something from a natural supplement given to them. So that's really, really important to know. I think another set of ears or two to come with you is always helpful for taking notes and asking questions. And then asking for copies of your test results. Ours are released immediately through the portal. So that's a good way to kind of keep track and feel like you don't have to write everything down. Second opinion, I think people oftentimes are shy about letting us know that they're going for a second. I think it's really, really normal to go for a second opinion. And so it is not something that we take offense at all, and I think is encouraged. I think, as it says, it's common and accepted and expected, and it can help you feel better about your decision. It is not too late to get another opinion, although I would say that there are some timing considerations. And so the things that come up are that, and this is why it's good, I think, actually be open with the doctor that you're interested in getting a second opinion, because they can usually help some with that. So sometimes people are getting a second opinion. There's a lot of different reasons. And this is when people come to me for a second opinion, I kind of want to find out what is it they're looking for. Sometimes they're coming to just to say, I've got my doctor here. Do you agree? If so, great. I feel very reassured. And that's a perfectly good reason for this. But some people are coming because they want to see if you have different options. And so the timing of when you go to see someone can be affected by what you've already done. So sometimes people will want to be on an experimental trial, for example. And if you start your treatment or your midstream treatment, it would be very unusual for you to be eligible for a clinical trial. Clinical trials sort of work at like predefined moments and typical transition points for treatment. So if you just started or you started a month ago and you're looking for an experimental trial, it is possible to have missed your window to go on a frontline experimental trial. And so usually when people ask me, especially when the patient visit, I know there's it's a lot of overwhelm, and it's hard to make those decisions quickly, but there are some degrees of where it makes sense. And so, some places, some big places will not actually schedule you if you're kind of midstream. We don't have that at my practice, but there are some places where their kind of main focus is experimental trials, and they will only kind of schedule you where you are kind of at a time where that trial could be considered. So not too late, but the timing can be affected. But I don't think you should worry about hurt feelings. I think, when I'm doing a second opinion, I always try to be really, really careful. Because sometimes people say, okay, well, you'll tell my doctor what to do, and then they'll do it. And I mean, you're also seeing an oncologist who is a collaborator, and I shouldn't be telling them what to do. If someone's seeing something in my area of expertise, there's not usually a reason that we're not coming to a shared treatment plan, but it isn't, presenting it like it's a second opinion and you're getting that in this, I think, maybe a slightly better way to phrase it with your ongoing oncologist. And really, with your ongoing oncologist, if you don't trust them at all, then that's maybe not the right place to so. How am I doing on time? You doing okay?
I'm doing good.
Okay. Any questions about second opinions? I think sometimes folks feel really uncomfortable about that. Okay. So, how do we affect treatment decisions? So, the type and stage of the disease, the results of biomarker testing, and certain talked about age and overall health. Sometimes other issues or other medical problems may affect whether or not the exact chemo is a good option for you. So medical history, sometimes how you did before with things will affect what we would make a recommendation for the next form of treatment. And then of course, some people will, there's some people who, if it's going to be a 2% benefit, they're great all in. Other folks, well, that's not worth it to me to go through things. And so I try as hard as I can, and I think most of us do, to try to give that information and work with patients to find out, what is of value to you, and how can I get that information to you in a way that you can make the value decision. So I can't make a value decision. I have perfectly reasonable people who walk through my door who come up with opposite conclusions. And so they're both valid. Every now and then, that's crazy, but most of the time. And sometimes people will just say, just tell me what to do. And I will, if that's what they want. But I've now been a doctor for 20-something years. And so in how I was raised is we don't tell people what to do. We be part of our patient. So anyway, so goals of treatment. So for earlier localized disease, ideally we're removing the cancer cell or killing the cancer cells in place and keeping the cancer cells from returning, showing up in other organs or in the organ where it started. And then for advanced disease, most often the goal is to slow or stop the growth of cancer cells, and that is with the goal of helping people feel better and or living longer than they would without the treatment. We definitely want to, I think quality of life moves up in the priority list if we do not feel that we can get the cancer all the way gone. I would say that for colorectal cancer, even in advanced disease and even in stage 4 disease, depending on how it's distributed, we can still cure it. And so it's important to know that, and definitely important to see someone who's thinking along those lines and understanding more why we might or might not be able to do that. So as we said, a surgery can be used to cure patients. Usually we have to eliminate all of the disease, and then rarely in those kind of very specific subsets of patients who have response to immune therapy, that also sometimes can cure patients. As you know, there's a lot of nuance in this, and so making sure you communicate with your healthcare team and feel like you can ask them questions and understand what's happening. So this goes, yeah. Were you asking?
No.
Okay. So lots of different types of treatment. Surgery, I think, is everybody probably understands. Ablation is not super commonly used in colorectal cancer, but it's a type of, in general, means that the interventional radiologist has gone in and put something into the, most commonly in the liver. Sometimes they will ablate like a kidney tumor, but we don't typically have that situation. It sounds really great, but it only has a very small, narrow area where that's helpful. Chemoradiation is a term where you give chemotherapy and radiation at the same time. That is most commonly used in rectal cancer. Radiation requires that you typically over a period of time. Colorectal cancer, sometimes that's 5 days. Most of the time that's 6 weeks. Both of those are different ways that they calculate dosing. But the rectum is in, because of the way it is anatomically is fixed, and so you can radiate it. The colon does this all the time, so you can't really reliably radiate it. So also the colon, because it's so long, you can get really good, you can feel like you get your hands around it in the surgery. The rectum, again, based on the location of it, it's hard to dig in and get to be as confident that you've gotten a full surgical resection, and so radiation kind of developed out of that concern that the surgery might not be fully complete and you needed to sort of clean up the mess. Sorry, my dentist is either going to call on the schedule or ready about an appointment. I'm guessing because they're calling that they're going to reschedule again. If they're scheduled. Sorry about the buzz. Anyway, so radiation, most of the time we do chemo and radiation together because it seems to be particularly effective in colorectal cancer. Radiation alone in colorectal cancer is most often used for an area of spread, typically the bone or possibly the brain, to treat mostly symptoms, as opposed to radiation alone is not thought to be kind of tumor control for the primary tumor. And then chemotherapy, immune therapy. So chemotherapy attacks the cancer cells directly, whereas immune therapy stimulates your own immune system to then go and attack the cancer cell.
Did you see the question?
Yes, I did. So I'm pulling that up. Can you explain a bit more about why you're saying surgery might not be as certain to remove it in rectal cancer? Yeah, I know, I don't think I did a good job with that. So basically the rectum goes through the I don't know if you can see, you probably even can't see my hands. I'm trying to show hands. You probably can't see them. And oh, I kind of see my picture. But if you think about kind of, you know, it goes through the bottom of the pelvis. And the same way that like a baby would get squished coming out of the bottom of the pelvis, the rectum is there with lots of other structures around it, the bones, the other tissues. So I think historically, it was hard to know how wide to go in the rectum and how deep and you were trying to spare a lot of other really important things like the nerves down there and the sphincters and all of that sort of thing. So we're talking, let's say, 30 years ago, that they developed radiation following surgery for rectal cancer only, one, because you could radiate the area, and two, probably the higher risk for the cancer coming back in that area, meaning that there's probably something left behind. There's been a ton of innovation in surgical techniques since then. and additionally, now we do primarily for rectal cancer, we do the treatment before we do the surgery rather than after we do the surgery. All of that increases the likelihood that we would not have what we call local recurrence in the rectal tumor. But that was kind of how we got to the two reasons to do radiation. One, you can do radiation, and two, we saw that it was more likely to recur in the area of the rectum, and so radiating decreased the likelihood of that, but it also increased the cure rate. So I don't know if that answered the question. I think now with proper surgical technique, so someone who's used to operating on rectal cancer, I don't know that it's as big of a component, but radiation still remain. There are studies ongoing evaluating whether or not we would eliminate radiation altogether, or can we de-escalate radiation from the treatment of rectal cancer. But once you sort of decide, once we sort of get something in the standard of care, we have to do a lot of studies to de-escalate, and want to be really careful that we're not setting people up for cancer recurrence or lowering the cure rate. So I'm going to please feel free to type more in the chat if I didn't explain that fully. Where is the cutoff really for radiation or not starting with surgery for what is in the rectum versus what can be treated at the colon? Very good question. So it is typically what we call the peritoneal reflection, which is back to this like lining of this, space. The peritoneal reflection is sort of the bottom part of where the belly cavity is. It's something that's very difficult for me as a medical oncologist to tell, and I used to have to pin my surgeons down and say, was it above or below the peritoneal reflection? And sometimes they can kind of tell from a colonoscopy, but it can be kind of difficult. If it's really low, it's easier. When we've done some experimental trials, they would use a rule of thumb like 12 centimeters in from the anal sphincter, but it can be a little bit hard to tell. There's also, I think, a little bit of question of if a patient is not going to need a permanent ostomy, permanent bag, how much more benefit do you get on top of now more effective chemotherapy, more effective surgery for doing the radiation, and who can be spared? We're looking at a lot of that question. So for high rectal tumors, how does peritoneal reflection relate to rectus sigmoid junction and location? It's on there. It's intermingled. So it would be very hard for me to give a clear delineation of exactly where a tumor is. Usually, if we call something rectus sigmoid, we're probably pushing it more into the colon, probably more into the colon path of treatment. But I have to ask often our colorectal surgeons really like where they feel this is and how much benefit they think, is this someone who really would feel like needs radiation or not? I know that's sort of a wishy-washy answer because it's still wishy-washy to me about telling where's the line for real. It's hard to tell. Question. So we talked a little bit about so sometimes when we say chemotherapy, we mean all of the systemic therapy, like all the medicines. And sometimes we mean very specifically chemotherapy is the medicine that kills the cancer cells directly, and immune therapy is medicine that boosts your immune system's response, and then the immune system kills the cancer. And then targeted therapy is something that's not chemotherapy, meaning it focuses very specifically on something particularly abnormal about that patient's cancer. So targeted and chemotherapy there's some overlap there. That other people like to say immunotherapy is targeted therapy because so it gets a little wishy-washy, but they have different side effects typically, but even down to the level of drug, they have different side effects. And then participation in clinical trials can be at any level of this. So we have surgical clinical trials, we have trials that I talked about de-escalating radiation, or we have clinical trials where we're looking at new drugs or drugs in different stages. So maybe moving something earlier. Immune therapy, for example, is being considered to be moved earlier in specific instances in the after surgical setting, for example, but it's still experimental. So yeah.
Quick question. Is anyone using proton therapy?
So for colorectal cancer, it's not typically being used. Or the data is not yet convincing us any better. I shouldn't say that because I have a patient who went and had proton therapy. I think there's not particularly strong data yet in colorectal cancer, is I think what I would say. It's usually used, proton therapy is usually used for something where millimeters matter. So the kind of the poster child is for pediatric brain tumors, right? Teeny brains, tumors, every millimeter matters. For rectal cancer, for example, we go in and we actually want to take extra millimeters, like that's our whole goal. So proton therapy doesn't necessarily line up as much with the need, but I'm sure there'll be ongoing, and we may find out in 5 years that proton therapy is exactly what we use, but right now it's not standard, and I don't feel like I'm missing much by that having information.
Question about clinical trials. Phase 1, are those heavily weighted towards immunotherapy these days, or?
It's interesting because just to catch everybody up in the room, phase 1 is usually early, it's early for patients. It's usually new drugs or drug combinations to people. There are definitely a lot where immunotherapy is used in a phase 1, and to try to particularly find ways to extend the value of immunotherapy to other drugs. Immunotherapy is used in all our trials. I think there's been a pendulum swing. I was all ready to start one of my studies, and this company said, we're only doing immunotherapy studies. All right, so then we didn't do it, and that was going to be a phase 1 combination. And then they've swung a little bit back, realizing that that's not that they have to also look at potential targets. And some patients won't respond at all to immunotherapy. So there's a lot, yeah. But immunotherapy is at phase 3, phase 2, phase 1, all of it. So yeah. So let me see. I know we're approaching. Maybe we have about 9 minutes. So I'm gonna.
We've actually got till 1:30.
Oh, do we? Okay.
So we're good.
Okay, sounds good.
We'll leave some time for questions at the end.
Okay, sounds good. So for surgery, goal is to remove as much as possible. And we can talk as much a little bit about the different types of surgery if people are particularly interested in that. Colostomies and ileostomies. Some patients will have a temporary colostomy or ileostomy, and the surgeons do that mainly, I think, to make sure that they kind of do things in 2 stages so that they get the cancer out and then allow the healing to happen. And I couldn't tell you exactly how they make all of the decisions of when they do and don't. Other folks, the location of the tumor is such that in order to feel confident in getting all of the cancer out, the anal sphincter has to come out as well. And in that case, there is not an option to not not have a permanent colostomy. And so again, that's where the colon, instead of going to the sphincter, goes to a bag, usually on the lower part of the abdomen. But surgery, side effects, initial pain, respiratory infection, scarring, adhesion. And then it really does, when you take out part of the colon has a job, and it's to help, the colon's job is really to take most of the water out of the food. Digestion's done before that. And so, there's a lot of adjustment in terms of long-term, how your body's going to react when you eat, and your bowel movements. They do improve. It does improve over time, but oftentimes may not go all the way back to normal in terms of how your bowel movement pattern had been before, or how your body responds to eating. So these are just some of those examples. And then I'm going to skip over this because it's not super common. Chemotherapy, we talk all day about chemotherapy we like. As we said, it uses drugs to destroy cancer cells. The terms neoadjuvant is when chemotherapy is being given before surgery, or adjuvant is when it's given after surgery. The goal is that certain number, the traditional model is that a certain number of patients are cured with surgery. We give chemotherapy in addition, and the reason we do that is the hope that more people are cured by the combination. We wish we knew which patients were already cured with surgery, and we wouldn't give them chemo. We knew wish we knew which patients the cancer was going to come back anyway. We also would not give them chemo, and we would only give chemo to the people who are going to be in that incremental cure rate. That's the holy grail of biomarker development, which we don't know yet, but we're working on. And so chemotherapy can be given in an IV or in a pill form. I would say both in colorectal cancer, it can be IV or pill. There's a perception that pill is significantly easier to tolerate. I do not think that is the case in the drugs that we have. It's more convenient to take a pill than to do an IV. For some patients, it actually can be a little bit harder on them from a side effect standpoint, but we have both options. But not all drugs have both options. We have both drugs for colorectal cancer, the backbone, 5-FU or capecitabine, both can be, are basically, again, two sides of the same coin. Not the exact same drug, but seem to do pretty much the same thing at the side of it. Radiation uses high energy rays to kill or damage cells. As we said, used in rectal, not colon. Maybe given before, during, or after surgery. There is intraoperative radiation. It's not really used in rectal cancer at this point, but and most commonly now, if we know that someone has a rectal cancer, they will generally get their treatment beforehand unless there's a blockage and they really just need to go on to bypass surgery beforehand. Side effects can be burn, skin irritations, much less common than what you see with for breast cancer. Obviously, the target is deeper in, so you often don't see as much in terms of the skin irritation, depending on the location. Although over time, you can have diarrhea that can also add to the irritation and pain at the rectum itself. Pain and swelling can have scarring or sometimes even narrowing, causing a blockage, or you can have incontinence after radiation where the sphincter doesn't, just the nerves just don't work really well. And this can affect both directly and as a consequence of the kind of emotional response, sexual health, and there can be effects on fertility as well. And then, as I said, chemoradiation is given at the same time, and that's typically where we do it. Most common targeted therapies in colorectal cancer target, we use EGFR inhibitors, which is the epidermal growth factor receptor. Interestingly, that was one of my fellow projects that was discovered at Vanderbilt, so we feel pretty affection for that pathway. But the target of that, how we identify patients for that is also interesting because we look for basically the double negative. So if someone has a RAS mutation, they won't respond to an EGFR inhibitor. it's a little bit different than finding a target and the drug matches the target. This is we pull out the people that we know will respond. We also can use that and use EGFR inhibitors in combination with BRAF inhibitors, and that seems to be more effective. So EGFR inhibitors are often used for patients at some point in the course of their disease. VEGF inhibitors, most common being Avastin or bevacizumab, although there's also in some pill forms, Stivarga or regorafenib. And these are only used in the metastatic setting. When it was looked at in the localized setting, didn't seem to be helpful. So why that is, lots of medical debate. We talked about that, but the short answer is we don't know, but it doesn't work. It didn't work. It didn't help patients, so we don't use it. And then kinase inhibitors, which made actually EGFR is a kinase and VEGF is a kinase. So kinase inhibitors are sort of different ways of targeting different proteins. So general side effects. We can talk as much or as little about this as you guys want. And it can vary a lot from person to person, and it varies from drug to drug. But these are kind of the general ones that we most commonly watch for and worry about. You know, some of these are really problematic in the short term and then go away pretty predictably. And then some have a way of hanging around and being actually more problematic even after we stop. So most notably, the neuropathy or numbness and tingling in hands and feet peaks at 3 months after you stop the drug. So trying to make sure that we don't overshoot when we're treating someone, but making sure they get all the benefits. That's a tricky wicky thing to do. The cold sensitivity, which is really common with oxaliplatin, goes away pretty predictably. Although some patients will note that they still, don't love to get their hands and feet cold down the road. But whereas nausea and vomiting is pretty horrible, but once you're done with treatment, you don't have it. So, it's literally pick your poison, right? But trying to work to understand, sorting out between the long list of things that can happen and what's most likely to happen, I think is definitely a kind of ongoing conversation with your healthcare team. And in some ways, hard to predict right up front. We can give sort of a general, this is what happens for most people, but any questions? Yeah.
I have a quick one. Just because what I have is my own experience and a lot of anecdotal stuff. How often would you say you reduce or remove oxaliplatin from the cocktail for neuropathy purposes?
Yeah. So as my uncle likes to tell us, you should always answer it depends. It depends. He's a psychologist, so and it does depend. So now that some patients are treated only 3 months, in the localized setting, right? So in the advanced setting, always, right? Because eventually they'll, well, I guess sometimes patients don't respond if they are being in the advanced setting. And so their disease might progress before they got neuropathy. But in general, almost everybody who continues on oxaliplatin will get neuropathy. So it depends on how long we're going to treat them for. And some patients we can treat for 3 months now. Most patients we treat for 6 months. And I would say probably it's maybe 30% or less they'll get full dose for 12 total treatments. Most will have some degree of decrease towards the end. And there's just been recently some interesting presentations about, it seems to be okay to decrease, especially after 3 months. And it's interesting whether or not we could have just a plan to stop at 3 months. I think that's where we'll look in the localized setting and still do just as well or not. Again, it gets down to is it okay? Is it okay because it's just a 1 or 2% difference? And is a 1 or 2% difference okay to everybody, right? Like some people that's not okay. Like, they don't want to take that risk, right? So yeah, but a lot of times. And I usually feel pretty comfortable. Like when the effect size from the 5-FU or the capecitabine in the backbone versus the oxaliplatin, the effect size is a lot bigger than here, and the side effects are a lot bigger from the oxaliplatin.
Thank
you. Okay, immunotherapy, everybody's really excited because although it helps only a small number of patients, it does really, really well when it works really, really well. And so we're working the, big picture, we're trying to find the patients who were likely to respond and then find ways to make the everybody else get that benefit as well. So specifically for colorectal cancer, it's primarily MSI high or those patients with deficient mismatch repair, although looking at ways to combine immunotherapy with other agents and extend the benefit. It is definitely, immunotherapy is thought to be, and most of the time people getting immunotherapy feel generally better than people with chemotherapy, although immunotherapy can be lethal. I mean, we definitely have patients who, if the immune system gets fired up, it can attack the wrong things. It attacks the wrong things like the brain or the heart, or sometimes even the lung or the gut. And most of the time we can manage it, sometimes we can't. And so it's why we don't want to just start giving it to everybody, because there are patients who have problems, even very serious, life-altering or life-limiting problems. So just being in communication with, these are pretty straightforward, ask about preventing and having information about what might be short-term and long-term side effects, and keeping your team informed. So bowel issues are very common in colorectal cancer, and it can be caused by the cancer itself or the treatment. Symptoms such as belly pain, nausea, vomiting, bloating, inability to pass gas, constipation, or diarrhea, or sometimes alternating both, which seems to be the most common for my patients, and so hardest to manage and easy to overshoot, and then loss of appetite. So talked a little bit, clinical trials or research studies that test new treatments or new treatment combinations, and they can help us to learn better how to use our existing treatments when we do and don't want to use those treatments. And you should always be able to leave a clinical trial anytime should you try. Palliative care, there's a lot of misconception about what palliative care is. Palliative care, the goal is to improve quality of life for patients and their families. It's really looking at ways of focusing on symptoms, and it can be given at any stage of treatment with active chemotherapy and radiation. It's not the same as hospice care. Hospice care is particularly focused on the end of life, and palliative care physicians often are overseeing hospice care because they're the best ones at symptom control, but they also help us with patients in active therapy too. So it's a team of healthcare providers who work closely when we're doing it right. So lots of recommendations around follow-up care, and this is always a little bit in evolution. Even this CT scan every 6 months and then year one is a little bit up for debate depending on which guidelines you look at. But in general, you'll see somebody with a blood test, most commonly a CEA, which is a protein that colorectal cancer cells make, kind of like a PSA. For prostate cancer, this is not as good as PSA. It's not as exact as PSA. Lots of other things can make it elevated. But if we watch it to just sort of get a trend, you'll see you get an exam, and then most common in the localized setting, most commonly once a year, sometimes every 6 months for particularly high-risk patients, and then in the advanced setting, it's a lot more frequent. One, to see how the disease is doing, but two, to just see, make sure that your cancer is continuing to respond to therapy. Colonoscopies really need to continue forever for patients who have the history of colorectal cancer, it gets a little bit nuanced on how frequently need one within a year from the original diagnosis, and then depending on those results and your age of diagnosis, it may space out a little bit. This is about coping. I would say our survivors are probably better at giving advice around this than I am. But certainly this is a big impact on both the patient and the family. It affects their sexual health and fertility. I will acknowledge that fertility planning in the setting of a cancer diagnosis is really complicated. It's really hard. They're dependent, even we say it's easier for men to say because you can sperm bank, and that technically is easier and quicker. Even that still can be difficult for patients diagnosed, with dealing with a new diagnosis. But for women, it may involve an extra surgical procedure, and some delay in treatment. There's just a lot of complexity around it. And again, it becomes a very individualized treatment plan. But it's easy to say we need to make a plan about it. It's actually hard to implement, just to be clear. And then, it's interesting. There's not a lot of data around in colorectal cancer, rectal cancer specifically. I've had several gay men specifically where have understandably really good questions around safety, and there's not great data. So there are folks interested in studying, but it is hard to find a lot of guidance. We work with the rest of our behavioral health team, and a lot of supportive listening, but it is an area that I think in medicine we are just now starting to ask good questions around, but not yet with lots of definitive answers. So quality of life, this is, I don't think anyone has any question that this is a really big deal. It can be both physically and emotionally challenging. And you guys connected with Gilda's Club, which is the best thing to do. So, anxiety, or maybe not a full diagnosis of anxiety, but what we would refer to as adjustment disorder with an anxious mood is definitely common. So as oncologists can sort of do some fairly easy interventions. We also partner with what we refer to psych oncology, and so some behavioral health providers that have particular interest in cancer patients and particular experience with that. So those are resources that are available. I think the other, this goes.
Yeah, it goes on.
Okay. What goes on for a bit?
It goes on quite a bit. So we can kind of wrap it up around here. And
Yeah, I think that's good.
For questions, but just to kind of state the obvious, we have a colorectal cancer support group. And we have lots of other things that can support folks during their treatment, after their treatment, family members all along that path. So, I mean, that's it. We like to work in conjunction with you guys because, you take care of the medical part, we take care of the other part, and that, it takes an extra step to reach out to a place like this, but it's so worthwhile to meet them. Oh, yes, me too. Just having that connection and, learning how to ask these questions that maybe, you have a question that someone else hasn't thought of, and just being able to connect in that way to bring those questions to your physician. So, yeah, this is obviously very important. I don't need to skip over it, but I also want to make sure
It's your wheelhouse. You guys have found
But yeah, so we can shop for support and letting your physician know if you are having these issues that, man, it's important to bring that up, and that hopefully they can address the medical part of that, but then the other part. So, questions about anything? Is there?
I have a question. I'm not sure if someone just asked it, but I had to step out.
That's okay, that's fine.
I couldn't ask my question.
what is it you tell your patients about Gilda's Club? And do you tell every patient? Is it selective?
Yeah.
And it's good for us, our team to hear,
Yeah.
as well as, the members that are with us already understand.
Right.
But it's helpful for us to hear what doctors are saying.
Yeah, so I would say I don't tell every patient about Gilda's Club. I think every patient, I have not the only person in the team, which is wonderful. I think, you guys know Julie, and I think she gets the word out very well about Gilda's Club. I think I particularly bring it up for patients who seem to be struggling, who are definitely asking questions about emotional wellness, coping, sometimes people will talk about that they're the only person with this, or that their friends are feeling isolated from their friends, or those kinds of phrases are when I will bring it up. The other component is around when people have trouble wanting to talk to their family, their kids, their spouse about things. Those kinds of things will be the time when we talk about this. What am I saying? I mean, I guess I think I've mostly commented that I've had patients who found this is really rewarding, and I feel like that they can go to the space and hear about other folks' experience, that there are certain patients that's really been that's been helpful to them to get through what is a particularly difficult time. So I often will just follow on what it is that I think that they need.
In a different kind of way. I didn't ask you to put you on the spot.
No, it's fine.
I asked you because both it's helpful, and I realize there's lots of people who can provide the resource, and we want to be a resource in many
Right.
places. But sometimes it's, when you mentioned you knew you had a patient who came to Gilda's Club and found it helpful, that's a really interesting flip side for us to know that patients are talking to their care team about being a part of Gilda's Club, that it works both ways.
Oh, yeah.
And it's just interesting to, we only know what we know
Mm-hmm.
when you walk in the door. So it's helpful for us to know what's happening before our members find us, and if there's other things we can do to make sure people know about us, and or, it's just so helpful.
Mm-hmm.
So thank you for that.
If I could just add a piece to that, I was pretty much finished with my treatment at Vanderbilt before I had heard about Gilda's Club from a friend, but it went right over with, so overwhelmed in the beginning. But nobody on my care team mentioned it, and I was the soldier of the family, thinking, I got this. I just went to work.
Mm-hmm.
My wife is actually who brought me and my family here, because she needed the more of the caregiver group, and then I joined the colorectal group, and it changed my life so dramatically that I'm glad I found it when I did. But it certainly could have been more helpful. And I think most people would have looked at me and thought, he's doing okay, he doesn't need it. I didn't know how much I did.
Yeah.
So if I were to make a suggestion, with all respect, I think mentioning it to everybody would be a positive thing, whether it appears they need it or not. I didn't know how much I needed.
Yeah. Thank you for that.
2 cents.
I give you $1.
That's why we keep them around.
I think there's so much information that you've given us today, and during my treatment, so many things were nebulous, and until something happened, like rashes or the et ceteras that were addressed here. And then one of my daughters would say, oh yes, I should have discussed that with you, that could be a possibility. And she apologized so much, because she said, there's so many things that we're not cognizant of in treatments. And I wish that there was some way I could just give you information enough so that you wouldn't be frustrated by not knowing. But then she also said, and you have often said this, is you're doing all this research, but there's so much more to do. And so there's not an explicit way to finally come to a conclusion. It's very individual and ongoing. And I really want to stress ongoing. And as a single person now, I lost my very best friend and fiance 2 years ago, exactly on April 3rd to COVID. And so my family is not in Tennessee, although I have some really great friends from the profession I'm in and from church situation. I just was not aware that it could really make a difference, for instance, to go to the colorectal meetings. I thought sometimes I would do it, but then there would be 2 or 3 cancellations over a period of 3 months that there just weren't enough people coming. And I decided I don't want to be the only person there.
COVID has complicated life in all kinds of ways. So I'm
Yeah.
glad you're here and
It's great to share these things. I didn't think it was going to be necessary, but I really wanted to hear you, Dr. Goff, because I just think you're exceptional. And you clarified so much. If I had known some of those things in the beginning, I wouldn't have been so, why is that happening?
You know, it's hard to know all the stuff, right? It's hard to absorb a lot of information, and there's a lot of information to absorb, so.
I would really like to see Gilda's Club, and we might already do this, have one-on-ones with people who have the same kind of cancer. Is there such a program?
Yep. It's more of an unofficial program that you've been on the receiving end of those phone calls when someone has reached out to us and said, I'd like to talk to somebody else who's gone through this. And we just reach out to folks and connect them, and then they kind of take that via email or phone or meet up or whatever. But yeah, it's helpful to hear from somebody who's been there and done that, and swap stories and compare and get advice.
And sometimes a group setting is not comfortable for everybody. We've had people come into the group once and not come back, and maybe they got what they needed, but maybe they just didn't feel like it was the right setting. But sometimes an individual relationship with somebody else who might be in the group is the best, works better for some people. So one-on-one informal.
Sarah had a question. So she said, for early in the process, how should a patient choose a specific GI oncologist, or do they get scheduled first available with the doctor who focuses on a specific type of location? So I don't know how every place does it. I can speak to what we do at Vanderbilt. And so it is, typically there are groups of patients or groups of doctors who would focus on a particular type of cancer. And we have some folks who do focus more broadly. And so within that bunch, we try to offer first available to a patient. If there's a directed or specific referral, we try to honor that, but that may mean that if there's a specific request, it may be a little bit longer before they would get in. So that's how we typically decide. But how should you choose? You should, but once you're there, you definitely want to be able to be with someone that you trust, and if the trust is schedulers usually seem to ask who you want to see. Okay. Well, I hope my people aren't asking who you want to see. I wouldn't expect you to know. So I'll give you know who that should be. You know, I think I think it's a good point. I mean, in general, if I have a patient who's in a different city, I often ask them if your primary care doctor can be a good source of information. People who've had previous treatment can be a good source of information. But then we have new people, you know, we have a new faculty member who started and he's amazing. And nobody's gonna know who he is yet. And they'd be lucky to see him. So anyways, it can be hard. I know.
Well, if you don't mind me, one source, you said patients who've had previous treatment, and the connection, I think, to those patients is their Gilda's Club. You know, if a new patient knew about Gilda's Club, was able to call here, like whoever takes the call might put them in touch with somebody from the colorectal group, and there might be a refer or a recommendation there. We've done it in the group many times. We just all talk about it constantly, and so again, Gilda's Club just rises right to the top of the.
People do call us in this panic of, I don't know who to call, and we are not in the business of recommending anyone. But I think sometimes just to have, like, we know that you work with people who have colorectal cancer, like just having a name to start with, I think is really helpful. And we are very careful to say, this isn't a recommendation, but here are some names that I have heard. Or do you want to come to the colorectal group? They don't, you know, it's not the only thing they talk about their doctor, but they certainly could share with you who their doctor is. So, I mean, it is really complicated because it's also coming at this time when it's like the worst possible moment to have to make this major decision. And then you have to make this huge decision. So there isn't a great pipeline for it, but I do think that we can be in some way to help people at least have a starting point of where to go.
And being on the medical resource council helps.
Yeah.
Because we have a list of doctors, again, not that we recommend for referrals, but who are supportive of Gilda's Club and who understand the value of Gilda's Club. So that's another kind of a self-pay. We appreciate it.
Dr. Goff, I want to thank you. That was really informative and really thorough. And this kind of talk is really helpful for a new patient. So I have one more question. I'm sorry, I asked too many questions. But I have one more question. If someone has a colonoscopy and the doctor says you have mild rectal thickening, some thickening, and that is the end of the conversation, would you go to an oncologist after that, or just stay with a GI doctor?
I'd stay with
and
the
follow
GI.
up.
Yeah, no, I mean, I think my experience with GI doctors are very committed to, eliminating colon cancer, and they're very dedicated to their patients. If it's just thickened, that probably would, my guess is they would suggest for something, a recheck relatively soon. But unless a cancer is really found in the rectum, the oncologist probably doesn't have anything to help you. They don't have any way to help.
Anything else? Anybody can think of?
All right, well, thanks.
If you can take the evaluations and fill those out, Emily and Sarah, I will email you a link to an evaluation. If you could fill it out, that would be amazing.
I'll grab one. I got it.
All right, thanks everybody.